in about a half an hour to 45 minutes, but what I thought was best is to kind of show you some emblematic cases that you can see, during your rotation, and that you see during your rotation in the ED. And feel free to stop me and ask questions. Unfortunately, like I was telling Dr. Willis, I can no longer use my pod because I'm maxed out on my storage. Because the images, it's just a lot of data. So we can still make this interactive. I'm just going to put cases up, take a look at it. You can just yell out the answer, and we'll discuss it, and we'll move on to the next case. It shouldn't take that long, okay? So I'm just going to show you a number of cases which will cover hemorrhage, stroke, infection, to a very lesser extent. This is in terms of a differential diagnosis. And we'll talk a little bit about a neoplasm. Now, when I say a little, I mean a really little. Okay, so here's the first case. This is a 32-year-old male post-MBA. And anyone can tell me, what do you see? The question is what, right? So what space is this hemorrhage in? It's in the epidural space. And what we see here is sort of a lentiform, hyperdense, extra-axial fluid collection that's in the right sort of parietal region. And you can see that it's clearly compressing the underlying parenchyma, and it's causing a midline shift towards the left. So this is an epidural hematoma. And what is the next thing that you should look for if you see epidural hematoma? You should look for a skull fracture, right? Because it's sort of, you can see right here at the bone windows, because about 95% of these hematomas would have an association with a skull fracture. So when you see blood in the brain in a patient with a history of trauma, the next thing we do is to look at, really scrutinize the bone windows to look for that associated fracture. Okay, and then this is a question I knew from since med school, but what vessel is typically associated with epidural hematoma? The medial meningeal artery. Okay, so we're going to talk a little bit about the epidural hematomas and what distinguishes them from other hematomas in the brain. So first of all, it's extra-axial. Second of all, it has a sort of what we call a lens shape or lentiform. It can cross the midline, because remember it's going above the dura, so it can cross the midline. However, it cannot cross the sutures, because at the sutures, the dural reflections are tightly adhered at those points. So they cannot get across the sutures, but they can definitely cross the midline. So we have three examples here, axial coronal image here. And you can see again, we have this sort of biconvex or lens shape, extra-axial, hyperdense fluid collection, which is going to be blood, that's causing a mass effect on the underlying brain parenchyma and a midline shift. Here on the coronal, you can see that it clearly crosses the midline. If you see that, you can know for sure that you're not dealing with a subdural, because subdurals do not cross the midline. We'll talk about that later. And again, here in the high parietal region, you can see that this hematoma is crossing the midline. And of course, you look for soft tissue signs to help you. This patient has a lot of extracranial soft tissue swelling. So teaching points again, most important thing, they're typically confined by the sutures, but they can cross the midline, like we said. They're typically lentiform in shape, typically, but they don't always follow the rules, associated with medial meningeal artery injuries. And another important thing to know is that they can also be associated with venous injuries, particularly at the posterior fossa and at the vertex. There can be some association with venous tears. Okay, what about this one? What space is this hemorrhage in? Very good, it's a subdural space. We see here that there's, again, extra-axial hyperdense, sort of a semi-lunar shape collection that's compressing the brain parenchyma, is causing a midline shift to the left. In addition to that, there's also some blood tracking into the interhemispheric fissure. Okay, so this is subdural blood.
What's going on in the middle?
This thing here? This?
Yeah.
It could be some blood, or it could be the choroid plexus that's sort of being smushed over. It's hard to see based on this image, and this is not my case, so I really didn't see the original image just to know what it is. But this is subdural blood here extending from the convex and into the interhemispheric fissure. So subdural hematomas, they're not confined by the sutures, okay? But they do not cross the midline. And typically we see them along the cerebral convexities, but it's important to look for them also where you have dural reflections. Here's an example of a case, a trauma patient. Here is what I love about the brain is that everything should be symmetric. So if you have a question and you're not sure what you're looking at, you can always sort of drop a plumb line down the middle and compare side to side. So clearly we see there's a discrepancy here. We see that there's this hyperdense linear focus along the falx. On this side it's normal. So this is an example of a pulsing subdural hematoma. Here's another example, not so obvious. We see here that there's sort of this linear hyperdense suggestion, like focus along the cerebellum and tracking here along the falx. Again, it can be subtle, but you compare side to side. Here this is nice and thin, barely perceptible. On this side, you can see that there's hyperdense focus along the falx. So we know that we're dealing with a subdural hematoma, particularly if this patient has a history of trauma. Any questions here? No. All right. So moving along, we have this other patient post-MVA. Came in, this is my case, came in at 9:25 a.m. with this CT. You know, on first glance, it may look normal, but when you look closely, you can see here that this is too dense, okay? It's not calcification, because calcifications in the falx tends to be chunky from one, not very linear. And so I suggested that this could be a subdural hematoma. Patient was rescanned, later on, as you can see here, it got rather big. So they can be that subtle. And there is some controversy about how to deal or how to manage these patients, because certainly no one's going to drain this, but certainly the patient warrants maybe some post-clinical observation. So again, be very careful along the falx to look for those subdural hematomas. And then you can see here the normal region of the falx anterior is very thin. Okay, it's very thin. And even back here, it's very thin, but when you come to this region, it's a bit thickened and it's brighter than usual. So that's what a subdural hematoma looks like, okay? Any questions there?
How could you tell the difference of that versus a subarachnoid in the same area? Could that is thickening also?
The subarachnoids tend to be within the cell side. And this is linear. Subarachnoids tend to first of all, they're not really arranged in this in this orientation usually, is within the cell side. This is right along the falx that divides the hemisphere. So that is the subdural space. Okay? Good. And another thing that comes up quite often, I think, is how do you tell the difference between atrophy and like a chronic subdural? I see it all the time. And I'll give you a few pointers here. So this is a typical, these three cases, typical for atrophy. You have enlargement of the ventricles, and then you have these sulci, which are rather prominent, and they extend out to the skull. They extend out to the bone, and that's very important to note, okay? And the MRI looks pretty much the same. You have just, enlargement of the ventricles, the sulci are rather prominent, and then, you have all this fluid here, which is just this extra CSF from atrophy. As opposed to this case, where you can see, here we have again, the extra axial collection. It's not bright. Of course, if it's bright, then there's no question it's a subdural. But when they become isodense or when they become chronic, it can be a bit difficult. But what you can see here is that on the left side, we have lost, can you see that okay? We have lost the cell side. They become effaced. Compare this side, nice and prominent and deep, as opposed, and this side, again, in neuro, if you drop that plumb line and you compare side to side, it's really helpful. You can see here that you've lost that sulcal appearance, and that there is slight mass effect. Chronic subdurals or CSF that's there from atrophy really should not give you a lot of mass effect. So here it is, we said these are subdural collections as opposed to just normal atrophy. Okay, any questions there? And of course you can have bleeding into a chronic subdural, so that presents another layer of difficulty. But in general, if you see the sulcal effacement, then you're not dealing with atrophy, you're dealing with the extraaxial collection. All right, this is a 32-year-old male with a very stereotypical worst headache of life. I mean, what do you see here? Right, so we can see here, there's a lot of bright foci throughout. Which area is this? This is the region of the suprasellar cistern, right? And instead of seeing normal cerebral spaces, what we're seeing is a lot of hemorrhage. This is subarachnoid blood, okay? And what study would you recommend? Patient would need a CTA, obviously, because the most common cause of non-traumatic subarachnoid hemorrhage would be rupture of aneurysm. So in this case, the patient had a CTA. You can see here nicely we're at the circle of Willis, axial, coronal, and sagittal images, and we can see that there's a focal outpouching of contrast right at the M1 segment of the middle cerebral artery, and that's compatible with an aneurysm. Okay? So subarachnoid, any questions on these images? Okay. Subarachnoid hemorrhage, like I said before, is overall the most common cause is trauma. If there's no trauma, then the most common cause would be a ruptured aneurysm in 70 to 80% of cases. There are other causes too, like vasculitis, if the patient has an AVM or carcinoma, benign perimesencephalic subarachnoid hemorrhage is another entity we'll talk about briefly. And a lot of times we just don't know why the patient has subarachnoid hemorrhage. So the workup, of course, we start with a non-contrast head CT. If there's a strong suspicion, you guys probably know that, you still suspect that there's subarachnoid blood, you can do an LP. If there is a spontaneous subarachnoid hemorrhage in a patient that has no trauma, then of course we need to do a CTA to look for aneurysm. If the CTA is positive, or even if it's negative, the next step is an angiogram, conventional angiogram. And as we're familiar with, spontaneous subarachnoid hemorrhages associated with numerous conditions, polycystic kidney disease being one, very common one. A lot of connective tissue disorders as well, like Marfan and Ehlers-Danlos, aortic coarctation, neurofibromatosis, and even fibromuscular dysplasia. So in these patients, there's a very high association with aneurysms and subsequent subarachnoid hemorrhage if they do bleed. Just to let you know, this is a very poor diagram I got off the internet. It's kind of blurry. But in terms of location of these aneurysms, the most common would be at the anterior communicating artery. 40% will occur here. The next common would be branches of the middle cerebral artery. Okay, so these are the two most common areas. And then you can also see them sort of like where the PCOM is coming off the internal carotid artery would be the next most common. Okay? So you can also see aneurysms on non-contrast CTs. It's just important to know what to look for. So in this patient here, it looks kind of normal, except that you're seeing this sort of like a hyperdense focus in the synovial fissure that has a peripheral calcification. The only thing that can really do that would be a blood vessel. That would be very suspicious for an aneurysm, and this patient should have a CTA. And you can note the other atherosclerotic changes in the IC on the other side. On MRI, what we tend to get are huge flow voids. So you see this big, sort of like blob of no signal where the ICA used to be. And you can kind of get a pulsation artifact, which I'm not seeing on this patient doesn't have that. But this again is 100% an aneurysm. And compared to the normal ICA on the right side, this is an aneurysm. And just to kind of show you an idea of how these things look like on CTA. So here we see the normal ACOM, anterior communicating artery here, normal MCA branches here, and then as we go down, keep your eye on the left, you can see that this blob becomes bigger and bigger. So that's an aneurysm that's occurring in the one of the middle cerebral artery branches. Okay. So take home point: see subarachnoid hemorrhage. If the patient the most common cause is still going to be trauma. Okay. But if the patient doesn't have a history of trauma, then you have to exclude the presence of an aneurysm and followed by a CTA. If the CTA is negative or positive, still patient should get a conventional CTA. All right. So here's a 32-year-old male with mild to moderate headache. Does anyone see anything? So this is one of my cases, and what I saw here was that there's very subtle high density blood. This is a non-contrast CT, so this is most likely going to be blood in the perimesencephalic region or the interpeduncular cisterns. Okay, this is the cerebral peduncles that are here in the midbrain, and there's high density there. It's not dense enough to be calcifications. Calcifications are really bright, almost like the skull. This is kind of like what blood can look like. And there's mild dilatation of the temporal horns of the lateral ventricles. Another image here demonstrates another patient, very obvious blob of high density in the interpeduncular cisterns and probably even coming along the perimesencephalic region. So this is an example of a benign perimesencephalic subarachnoid hemorrhage. And I mean, I've only seen maybe one or two. It's not that common. But they say it accounts for about 10% of spontaneous subarachnoid hemorrhage. It's thought to be secondary to venous bleeding. It's usually located right between those interpeduncular cisterns. And since the patients have very sort of like, headache, but it's not terrible, like the worst headache of my life. And it tends to resolve rapidly. But of course, this patient must still be worked up to exclude an aneurysm, so should still have a CTA and all the other necessary workup. Okay? Any questions in this? Sure.
If you just did a CTA, would you be able to see the blood?
You wouldn't really see the blood because at that point the contrast sort of like masks the blood. You can see, you'll see it, but not as not as well as you would see it on a non-contrast CT. The most important finding that you would hope to see in this patient would be no aneurysms. If you see nothing, then you can probably just say that's probably just benign. You can follow the patient.
Is that venous bleeding spontaneous?
Spontaneous. You don't know what it is, and it resolves spontaneously. The patients, I mean, the 2 cases that I had, they were fine. It resolves, it goes away, and then nothing happens. Hopefully, we'll see. All right, so this is a 68-year-old female, something that we see at least 2 or 3 times a week. Acute onset right-sided weakness, blood pressure 220 to 125. So the question is, what species is hemorrhage in? So it's a parenchymal bleed. It's not extraaxial. You can see here, it's an intraparenchymal bleed. We have this really hyperdense focus that's sort of like in the basal ganglia. It's still causing some mass effect, shifting things to the right. And there's some edema around this. This is a very typical occurrence of a parenchymal hematoma. And the history is usually an older patient, middle-aged older patient with very high uncontrolled blood pressure. So another cause of this too, which we should mention, is amyloid. Amyloid causes spontaneous intraparenchymal hemorrhage in these patients. And it's usually, the blood pressure could be normal, but just a sort of unfortunate thing of getting older, I guess. You can bleed. And sometimes in these patients, they can have like normal CTs, and then when you do the MRI, you see these blobs of very, very dark signals which indicate prior hemorrhage from amyloid. Okay? Tumors can also cause this. If you have hemorrhagic transformation within an infarct, this can cause this. And vascular malformations, particularly in younger patients, is also a common cause of parenchymal hemorrhages. So these hypertensive hemorrhages, they occur spontaneously, usually again in middle-aged and older adults. And they're due to rupture of what we call Charcot-Bouchard's aneurysms in the deep penetrating arteries that tend to serve the basal ganglia. So if you look carefully, you can see these penetrating arteries, and there are these small sort of like outpouchings on these penetrating vessels, and that is what ruptures and bleeds and causes these huge hematomas in the brain in these patients. The most common location, as you probably know, the basal ganglia, followed by the thalamus, the pons, and actual lobar bleeds are less than 10%. So we have a kind of 4 P's that we keep in mind in radiology. 4 P's for hypertensive bleeds in the putamen, the pons, the pulvinar, which is just a nucleus within the thalamus, and the posterior fossa or the cerebellum, the 4 P's, where we tend to get these hypertensive bleeds. An important thing to know is where these bleeds are, because depending on where they are, they can extend into the ventricular system. So here we have this large hematoma that's occurring in the left lateral thalamus, and it's extending into the lateral ventricle. Okay, so it's not necessarily a never have I seen hemorrhage that goes from the ventricles and goes out into the parenchyma. It's almost always from the parenchyma into the ventricles. Okay? So any questions in this one? Hypertensive bleeds. Good. So we have here a 70-year-old male with headache and weight loss. What do we see here? There's a very subtle hyperdense focus in the right parietal lobe. And then there's a lot of low density around it, which indicates that there's some edema. On another image, you can see here, lower down, that there's sort of white matter, vasogenic edema. And I'll just say there's a difference between vasogenic edema and cytotoxic edema. Cytotoxic edema is associated with strokes. Vasogenic edema tends to be associated with masses and infections. How you tell the difference is that vasogenic edema is in the white matter and sort of has a finger-like appearance, like fronds. You can see here, it looks finger-like that. That's because it's sort of confined to the white matter. Vasogenic edema results in blurring of the white matter and the gray matter equally, okay? So that is kind of how you tell the difference. So this patient has vasogenic edema and this hyperdense focus in the parenchyma. We do a post-contrast study here. You can see the patient has multiple rim-enhancing lesions throughout the brain. Okay, there's one here, the very first lesion that we saw. And there are others that we don't see. Again, stressing the importance of contrast is very important. You would totally miss all these lesions here if we didn't get, and several others if we don't give contrast. Okay? So at this point in time, the differential diagnosis is quite large. It encompasses infection, you know, if the patient has HIV, it could be, you know, toxo, cryptococcus, CMV, even lymphoma in HIV patients could present like this. The patient can have multiple sclerosis, sometimes can have these rim-enhancing lesions. Subacute infarcts can also enhance. It could be very complicated. Subacute infarcts can also enhance. We don't expect them to be so, you know, multiple all over the place. But if you just had this one lesion here, it could be a subacute infarct. A metastatic disease, of course, is very high in the differential diagnosis, particularly given its history. So when we look at the bone windows, we see that the patient has some lytic lesions here in the skull. And on the chest CT, he had multiple masses in the lung. So this is an example of metastatic disease. I'm not sure what the primary was. But the point is the differential diagnosis is quite wide, large, and we have to correlate it with the patient's history. If the patient has a known malignancy, then this is going to be met. If the patient has HIV, then we'll consider some different things. Okay, so the differential diagnosis we discussed already. Also added to that radiation, it can be very confusing. That's why the history is absolutely important. So there's some typically hemorrhagic nets that we should know, because the very first lesion that we saw was quite dense, which means that it was bleeding. So these are the cancers that tend to bleed a lot. Choriocarcinoma, thyroid, melanoma, renal cell, and islet cell tumors are very vascular and they bleed. That's what we should be familiar with those. Okay, any questions on this one? All right, so the next case is a 24-year-old female with persistent headaches. Anything? Does anyone see anything? So what we see here, you know, is very, very easy to sort of blow past this, right? But then again, remember the fold, we talked about it, right? The fold